Good morning, everyone. This is Donna Verna. I am here to introduce Dr. Mehrdad Ayati, who is well known nationally and internationally in the field of geriatric medicine. Dr. Ayati is a physician, speaker, author, and an educator. He is the medical advisor to the United States Senate Special Committee on Aging, providing medical advice on aging and challenges faced by the aging population in the United States. Dr. Ayati is an adjunct assistant professor of medicine at Stanford University School of Medicine, where he teaches geriatric and internal medicine. The doctor is currently on the front lines treating patients with coronavirus. I have worked with Dr. Ayati, and I have great respect for the work he does and a sincere appreciation for you being here today. Dr. Ayati, the time is now yours.
Thank you so much. Good morning, everyone. And thank you for inviting me. It's a pleasure to be here. I just want to check again. Are you seeing my slides at COVID-19 update for aging population? Hello?
Yes, I can see the slides.
Oh, perfect. You see it at the screen. Okay, perfect.
Thank you, Doctor.
Just see that some noise is going to be disconnected. Thank you again. It's a very critical time for all of us, and I just wanted to share with you some of the updates. Interesting, since the starting of the COVID-19 from January, actually, we've been speaking and presenting in different places regarding this issue. And again, the issue is coming that every 3 or 4 days, our presentation is actually changing because of what we get about this disease and this problem. Today, I try to a little bit talk about COVID-19, asking, try to answering some of the questions that you hear. Unfortunately, these days we have a lot of issues going on in our country and everywhere, because everybody has a different opinion regarding COVID-19 right now. And you hear a lot of things in social media and the news, a lot of anecdotal information. I try to make it clear first, and then we go from there. Now, the key point to learn today is what is the history of the COVID-19, what are the symptom diagnosis, management, prevention, future. I don't want to make it medical, but I wanted to just say a little bit about what's going on about this disease, and because we just need to a little bit know, and that can answer some of our questions moving forward. What's the story actually started? And as you probably hear in many things in the news, that again, it's the story started with a series of pneumonia, a cluster of the pneumonia on December 2019 in Wuhan and the city of the Hubei in province of China. That was very interesting because at the same time we had this outbreak of influenza everywhere in the world. We had a lot of mortality at the same time. And there was a big questions for people that, is this really influenza outbreak or this is something new? And because the Chinese people had experience with SARS, which I'm telling a little bit about it in the past, they were kind of like think about maybe the SARS came back again because we were able to contain SARS years ago. But then because the number has been increased and then they followed the new cases in Wuhan, then we have a new definition of coronavirus 2 or SARS-CoV-2, which on February, we just changed the name of the COVID-19. As you probably know, the story is the route of transmission of the disease is still, we don't know, still the transmission risk is incomplete. We know that possible it's coming from animals, especially bat, to some animals or some intermediate host, either a snake or either, as you see in the picture, pangolin is probably because of the skin has a lot of the layers and that probably can spread this virus. And that was the initial of the story. And you probably know that this virus is, which we call SARS-CoV-2. I don't want to go on the details of this picture, but as you see here, when we say coronavirus, we talk about these spikes actually on the virus. This is the what we see so far is the full genome sequencing of this virus, which is a beta coronavirus. It's technically is the same genus of the severe acute respiratory syndrome, which is we call SARS. And that was the thing that it was outbreak in 2008. And we have other group of the coronavirus, but this one is actually has a different structure, but it's very, very similar to the one that we have in 2003. But the only problem that we see so far, it's a very, very high contaminated. As you probably know, the type of the virus that we have Middle East respiratory syndrome, which we call MERS. MERS COVID is another beta coronavirus, which it's happened in the countries like Egypt and Saudi Arabia years ago. And there's a very closest RNA virus similar to bat coronavirus. But the only things we know that this kind of virus, it doesn't come from bat. Compare of these two is actually comes from the camel, and probably some intermediate transmissions that happen here. And that's kind of like from 2012 that we have MERS, 2003 we have SARS, and 2019 we have this virus has been changed, I will say probably in the last 20 years in a different area of the world, and now is just spreading so fast. Case fatality rate is changing everywhere. As you probably know, when you look at here, this is the total, 800 is the total number of the people die, and 8,000 is the total of people got infected. When we divided this to, it will be 10% case fatality rate for that. For MERS, we have 850 people, they actually died, and 2,500, when you actually multiply by 100, is the 34%, which is very high. But think about it, we have less number of the people infected. The COVID-19 12 till 24, I mean March 24, today is 26. As you probably know, the number is growing significantly around the world. We have 4.4%, but this number, it's lower than this two. But as you probably, the reason, because we have more people contaminated with this disease, they're not necessarily all dying. If you compare to this two, they actually have the higher mortality at that time, both SARS and MERS. But we're technically thinking about ranging from 0.7% that we have in China to 5.8. When we look at the numbers in Italy and Spain in the last 48 hours, the numbers are just getting higher and higher of the fatality. Definitely the people older age, which comes to my territory, anybody has medical condition. When we call medical condition, is not necessarily somebody has immunocompressive. Anybody has any cardiovascular disease, even have high blood pressure, anybody has diabetes, anybody has asthma, anybody smoke in the life and has some scar in their lung, or anybody has a history of the cancer, they're very, very high risk that actually die from this disease. Age is 49 to 56 years. As you probably know, this virus is mutating so fast. I mean, around 2.5 months this virus is mutating. You'll probably hear in the news we sequencing this virus, and we found that the virus we had in China is not the one that we have today. Is actually the RNA structure has been changed. And this probably is one of the reasons that we here in United States, more younger people actually getting infected, which is not happening in Wuhan. And even in Spain, we hear for the last 48 hours that actually people on 20 years old, 25 years old, they're actually getting infected. Mortality, by the way, it's more in older people, 80%. The children, they have more mild symptoms, and they have technically just a fever and mild fever, some muscle pain in the kids. And again, it's very, very uncommon in the kids. The large Chinese report, we have only 2% of infections in the people younger than 20 years old. South Korea, we have around 6.3 in 8,000 infection younger than 20 years old. And again, a smaller study in the China shows the kids only showing fever, resolve, half cough, some sore throat. They have little, I mean, just a very 4 or 5 cases in China, children had changing on the CT scan. One of the big things about this virus is about asymptomatic infection. And this is kind of like very amazing situation about this virus. And that actually makes us to be more scared about that. Frequency of this asymptomatic patients is unknown. We know that the COVID-19 outbreak in a cruise ship, all passengers and staff is screened for SARS-CoV-2. 17% of the population on board tested positive on February 20th. And half of the 619 confirmed COVID-19, they were absolutely asymptomatic at the time of diagnosis. Why I'm saying this is a strange, because when we talk about influenza, you never have a spreading of this infection of somebody is asymptomatic. You should always have cough, sneezing, and other symptoms. Measles and any other disease that we are kind of like talking about viral infection, you should be symptomatic when you're shedding the virus. But this COVID-19 is something else. Even the people is absolutely asymptomatic, and even they're not aware that they have the disease, they can be a source of the virus shedding. And that's, again, one of the things that we are kind of like concerned about these people. As it's about a 20 asymptomatic people. There's some study that we reviewing from China. One of the study, in the 24 study, they have absolutely no symptoms. They did a chest CT scan, and they found, interestingly, even they're not aware that they have a disease, they have a positive finding on their CT scan. And 5 of these people, they develop low-grade fever and maybe some typical symptoms. Another study done in Wuhan, it shows in 55 patients with asymptomatic infection, identified through contact tracing, 67% they have positive finding on a CT scan with pneumonia, and they were not aware of the disease. And only 2 patients from this group, they developed a low oxygen level or hypoxia, and then both of them, they are recovered and they didn't die of the disease. As you see here, transmissions from the coronavirus, which is, again, the main things that we discussed, 30% of the transmissions can happen in asymptomatic patients, which is very scary. Compare of the mild to moderate, which they have a little bit of the symptoms, the 56%. Severe patients, 10%, most of them hospitalized, and 4% is critical care. The reason is critical care is a less transmission because we following the protocol for the guideline for protection. When we talk about how bad is this virus, is we look at the R0, means 1% how many people can get infected from 1%. The worst one is measles. Actually, one kid can actually spread this disease to many people. When we look at the H1N1, Ebola, and even SARS, we kind of like COVID-19 from 1%, 2 to 3 people can be involved. And from that people, think about that we can multiply and we have more people then. Now, the most important question is how this disease going to be spread around. Definitely is a respiratory droplet, and which is important. If somebody's sneezing, coughing, you know it about it. They're talking in social media and also in the news about it. But one of the things is important that we notice that is also can be transmitted from the feces. We have many cases that have been reported in China and also South Korea and Italy and even the United States, that the manifestation of the disease was only diarrhea, and some of them nausea and vomiting. And that's why they can actually transmit the disease if somebody, like for example, go to the bathroom not washing the hand and touching the food and surfaces. And definitely indirect contact will be touch. Regarding the touch, we have some of the data available. We know that it can stay up to 4 hours in copper, and plastic is actually 2 to 3 days. The most thing is the plastic. Even the new study just been published yesterday, it shows that can stay even 5 to 6 days on the plastic. And that's something that we just know. But the only things that is very interesting is airborne. The airborne, we we have been uncertain about this disease, that it is airborne or not. We know by a study that has been published in New England Journal of Medicine, this virus can stay or aerosolize for 3 hours in the air. Now, that's a very important question. Like if you are in the room with somebody has coronavirus, COVID-19, and that person sneezes, up to 3 hours, the stuff can stay in the air. And that's one of the reasons that we are so worried about the healthcare worker, that they're working in the hospitals or they're working in the skilled nursing home or senior facilities, because if they are in like in rooms, if they don't have appropriate PPEs, there's a possibility the virus can actually go through their mucous membrane of the people. And that's continued the study, as I showed, in copper, cardboard, stainless steel, and plastic, which is a plastic is actually stay for a longer time. But the 3 hours, as you see here, probably is going to be the average time. Plastic is the highest one, as you see in the bottom of this picture, that is stay for a longer time. The incubation period of this disease, it's technically is a 5.1 day. We know about it that after exposure, in a study that has been done in 10,999 patients with confirmed symptomatic COVID-19, it's about 4 or 5 days, between 2 to 7 days. But technically, it can extend it till 11.5 days, which is a 97.5% will do within even 10 days, 11 days. And that's something that we should pay attention about it. As you probably know, that this is why we always say 2 weeks of the quarantine for everyone, because in the cases that we have so far, and recovery time after the disease finish is about 2 weeks for mild infection and 3 to 6 weeks for severe infection, that they can have recovery after the disease. Now, I just wanted to quickly say about that, because that's picture you probably, I'm going to come back again when I'm talking about in disease. As you see here, the way that actually this virus getting to the cells, like for example, or lung cells, it's through the receptor which you see here, ACE2, which I'm just wanted to show it to you here. And as you probably see here, this one, ACE2, it's the one that actually is important to know about it. And this one is, we talk about it, this virus is attached to this receptor and getting through to the cells. I wanted to say here, as you see here, the ACE2 receptor here, and I wanted to show it for you here. This is the way the virus gets to our system. Now, what the virus does, many of you know about it, the virus is using our cells as a slave, and technically ask the RNA, their RNA through our system to be reproduced. And when they reproduce, there is going to be an enzyme, which is RNA-dependent RNA polymerase enzyme, that start to make tons of the RNA for the virus. They also make a lot of protein. They assemble and packing this cells, and they made tons of the baby virus, which you see here. These are the baby virus that they're making. This is the cycle. I'm going to get back to this slide because it's important for you to know about some of the infection and other things that you wanted to know. This is the way this virus using our cells as a slave and making tons of baby virus for itself. And okay, I'm sorry. And this is the way we are. Oh, let me see. I think I did a wrong button. Okay. And as you see here, that actually can affect loss of the situation in our system. Now, as you see here, let me go to the. You guys hear me well?
Yes.
Okay, perfect.
Hear well.
Okay, perfect. Let me go to the. Okay. The initial presentation of this disease is fever, and as you are you know about a fever that we have. The issue that we have about the fever is that fever is not in all the cases. I will talk about it, but they definitely come with fatigue, dry cough, anorexia, myalgia, and which we muscle pain. Anorexia is a loss of appetite in 40%. Some people have a shortness of breath of initial presentation, less likely, but elderly people more. And then the other thing is a sputum production, which is in the 27%, which they may have a phlegm and productive cough, not necessarily dry cough. But the fever is not a universal finding. We have only 20% has a low-grade fever. There's a study we used to review in Wuhan in 10,099 5 people. We find that they may have very low-grade fever, which is 37.5 and 99.5. Only in 44% of people, like means 50% of people, they actually presented with no fever. But when they get sickness, they definitely is febrile. When they are very sick and they transfer to the hospital, they're febrile. That means that in outpatient setting, many people, they don't have fever. And the other things we have to remind, many older adult people, they cannot present with fever. Actually, the fever hasn't been reported in older people. And other symptoms that we see, which is, we talk about some of them, but like for example, rhinorrhea, which is a runny nose, a sneezing, sore throat, we can also see as well. But diarrhea, it's one of the things that I really like. When we look at the blood test, they may have some low lymphocyte. We may have some injury to the liver as well. We see the liver enzymes also is going to be high in these people. Loss of the smelling, which anosmia we call it. Anosmia usually is very anecdotally reported, and a lot of people, they're talking in France that initial presentation was loss of smelling. That's not correct, actually, in all the cases, because in some of the cases, yes, in influenza also loss of the smell can happening as well. In other viral infection can happen, but it's not necessary that everybody's going to lose the smell or tasting right now. They just worry about, oh, they got COVID-19. This is one of the alarming symptoms, but not everyone getting the symptoms. Now, most of the cases are mild based on the Chinese Center for Disease Control and Prevention and what we even see in other part of the world. And severe cases, it happened in 14% of the cases, which we have significant lung problem. And the critical cases, which is 5%, that directly they go to the hospital and then the ICU, which they go toward something we call ARDS. It's not a topic that we want to talk today. The best test that we can do is a PCR, which we do the nasal or oropharyngeal swab from the mouth or from the nose, or chest CT or blood test. Blood test, it hasn't been done in the United States. In China, they are doing part of the research right now, which can be very, very helpful in the future if we wanted to really looking for efficacy of the vaccine or anything else, but it's not developed yet in Europe and the United States. As you probably hear, you see that a little bit temperature has been started in, like, for example, and the maximum of the temperature has been gone up like 38.6, which is really nothing. I mean, compared with many other viral infections that they have a very high temperature, and dry cough, loose stool is actually being part of it. One of the big questions that a lot of people ask me about, if somebody is negative, is it true negative or not? The answer is actually the negative. It doesn't mean that we have negative, because COVID-19 tests can be negative in some people, even they are carry the virus. And there should be different reasons for that. It can be due to poor quality swabs that the persons are doing it, or it could be due to the fact that the virus has not made to the upper respiratory region if only nasal and throat swabs were collected. And this is one of the things is we have to remember. The other things, RNA virus, it's so sensitive. If somebody in the labs quickly touch the virus, with something plastic, it can be degraded so easily, and the test can be negative. That's why for doing this test, the person should be very well trained about how to do RNA virus tests. And this is one of the reasons a lot of people, they come negative, but they're really positive. And they come back 3 days later and they become positive. And I have many of the CNAs on the senior care facilities for the last 3 or 4 days with the similar scenario. And this is why the best solution, which is the WHO recommended, is testing for specimen from multiple sites, from nose, throat, back of the throat, to make sure this is the true negative. The other things is a CT scan. CT scan may be helpful, but it's definitely not ruling out, because one of the things we notice, as I said at the beginning, many asymptomatic people, they have a positive CT scan even if they don't have a symptoms. But if you see here on this picture, and I can show it here with the pen, here, as you see here, these two things that I'm pointing out here, these are, we call ground glass finding, and you have another one here. These are a typical for this situation that we have for this people, and that's something we have to pay attention to, ground glass opacity. But you can also find it in any other disease. This is what non-specific to do CT scan. I pull up all information about some of the articles you have in your hands out, but this is one of the best comprehensive analysis for diagnosis. And this is about the CT scan, and all of this article hasn't been come to the publishment, but they're all pre-proof that they're actually coming as well. If somebody is home care and positive for COVID-19, they just need to be separate from their pets and their people. When they are in home, they should use face mask, not N95, infected people. I will tell you why. And it definitely is so important to clean the area that the people touch. The most important question is when the person can be out of isolation. If there are based on the test, is whenever we have fever stop with no medication, and if you do the test and test becomes if somebody is test positive, and then you say, okay, when you can go out, either you can do the test in the 24 hours. If your two test is negative, you can be out. If there's no access to the test, if your symptoms getting better, like cough, shortness of breath, plus no fever in the last 24 to 72 hours without using Tylenol, without using ibuprofen, if there's no fever, you can be out of the isolation. If somebody is just in isolation, because think about, I may have this disease, no test-based strategy, they said if you have 7 days past since the symptoms started, then you can be out of isolation, plus at least 72 hours, there's no symptoms, no cough, no shortness of breath, no fever, and no any other problem, that you can be out of isolation. A lot of people have said, my test is positive, but I don't have any symptoms. That's true. A lot of people, as we say, they are positive, they are asymptomatic. They should be, home isolation can be discontinued when we have 7 days passed from the day that they are positive, as long as they don't have any other symptoms. The most important thing is a prevention. The focus on worldwide should be on prevention. The only way that we can contain this virus is that we stop spreading this virus. We separate the infected people from non-infected people. And this is the only way that we can do that. And definitely avoid the close contact, all other things that you know, I don't want to go on that, avoiding touch and anything else. Some of the tips that is important for you to know about prevention of the disease, which I wanted to share with you. The number one is that alcohol base should be at least 70%. Bleach, any bleach solutions can be also helpful. And you can make it by yourself, 4 teaspoons of the bleach per quarter, or 1 liter of water. And if you can do it by yourself to clean the surfaces. You don't need to definitely have a bleach spray or something. The most important thing I wanted to add is cook the food very good. The reason is, especially if you buy raw fruits or raw vegetables from the store, and the people touching it, they should be very careful about it, because then it actually makes the situation that somebody is touching this fresh fruit and you can get it. The other things, don't forget, when you get the food from the restaurant, if somebody has diarrhea and is a COVID-19 positive, and that person is making your food or packing your food, it can be contaminated. That food needs to be placed in a microwave for at least a minute, that the COVID-19 is going to be gone. Otherwise, you don't know that the person in the restaurant is COVID-19 positive and really contaminated the food as well. Definitely unprotected contact with farm or wild animals is so important. For long-term facility, as you know, we have to do a standard contact droplet precaution, addition to the eye protection for any patients that has undiagnosed respiratory infection, and we don't know this is a COVID-19 positive or not, because we know the skilled nursing home are the highest risk of getting this infection, especially you probably hear in the last 72 hours, many people died in Spain and Lombardy in Italy from the skilled nursing home. Many skilled nursing home, the people, the healthcare workers, they escaped from a skilled nursing home and their dead body found in the beds. And in two facilities in Madrid, entire facility, they've been dead in the skilled nursing home, and it's a very, very high risk of getting it. The questions comes from the mask. I just wanted to remind again, a lot of people ask, should I do face mask N95? Face mask is for sick people. It doesn't let the stuff going out from your mouth. N95, it doesn't let the stuff coming into you. For people who are sick, they can use face masks. I see a lot of people, they running in the streets with their dogs with the face masks. That's a joke. And also on the sad picture, I see a lot of people running with their dogs with N95 masks, which is a huge shortage of N95 in the country for healthcare workers. I mean, first of all, face mask is not going to prevent you from not getting COVID-19. This is a very small virus. It can go easily to, even there are some of the questions right now, they're talking about a N95 mask by itself. It needs to be double protected. The sad things about now, we're asking a lot of people washing their N95 mask, and a lot of fabrics is just getting destroyed right now. This virus, it's so fast and small, and it can get through even to the hair and then actually can get infection. I just want to quickly say, because a lot of the people talk about medication, you probably know remdesivir. It's one of the medication that Gilead company made it for Ebola, and it was failing Ebola. But this medication is now in the phase 3 clinical trial. We have one of them at Stanford as well. My personal experience, I can tell you, if the persons with a very sick situation get it in the first 24 hours, it shows that it's working. And again, I'm waiting for next week that some of the result of the phase 3 trial is going to come, but we have to talk about it. Regarding other medication, tocilizumab and lopinavir and ritonavir, which is for more HIV, I'm not talking about it. Regarding chloroquine, because it has been on the discussion of even the President Trump about it, let me tell you about the chloroquine. As you remember in this slide I told you, chloroquine shows in animal model, not in human. It technically blocked this receptor, as you see here with my pen, and technically not going to let the virus, influenza virus, not the COVID, comes to the cell in animal model. It hasn't shown in the human model. Now, there is a lot of controversial about chloroquine and hydroxychloroquine, that is it effective or not. We have one French study that has been in only 20 people. They give azithromycin plus chloroquine to these people. It's very interesting. The only things the French people found, 6 people from this study, they have less virus shedding in their nose. They didn't have a change of the clinical trial. They only showing that they have less virus shedding. One of them left the hospital before, and the rest of them, it didn't work. It's very, very uncertain about the use of chloroquine. And don't forget, chloroquine is not an easy medication to use. It caused a lot of GI upset, many other things. I can tell you for sure today, there is definitely very uncertain about this medication work. and I do not recommend to use this medication. Now, when we talk about the other medication like remdesivir, this is the enzyme that we talk that technically the virus tried to replicate more RNA. This medication blocked this enzyme and not let the virus to mix more RNA. And this is why this is the mechanism for remdesivir. This is the mechanism for hydroxychloroquine. A lot of people ask about, because of the ACE2 receptor or angiotensin receptor, the people on high blood pressure medication, angiotensin receptor like lisinopril, losartan, is it the bad that they're taking? I have to say, American Heart Association had a statement. It shows that it's really not so far. We're really not sure about that. But don't forget, the people with high blood pressure, diabetes, they really rely on this medication. And we know if we stop this medication, we can actually have an opportunity to really kill the people because of the very high risk of that. The other things about ibuprofen or non-steroidal anti-inflammatory medication, evidence limited to the anecdotal reports, that is definitely makes it worse. American Academy of Rheumatology shows that we don't have any special data that taking NSAIDs is actually makes the situation worse. For older adult, I just want to wrap up my presentation here and then just try to answer your questions. Older adult and with pre-existing cardiovascular, any people have lung cancer in the past, even has been healed, has been in recovery. Any person has a lung disease in the past, like a smoker, asthma, COPD, high blood pressure, which all of the older adults they have at this stage. Any person has a diabetes, they are very, very high risk of mortality. And this is so important that we understand. Diabetes, 6%, cardiovascular 10%, cancer around 6%. And that's something that we need to pay attention, that why these people are very, very high risk. The other issue regarding older adult is isolation, which has been discussed a lot in United Kingdom. The isolation is going to continue for the next month, which I'm thinking about that's going to happen probably. I'm not personally not very optimistic that we can get rid of this virus so fast. I think this is just the tip of iceberg. This is just the beginning, especially in the United States. I will tell you why. But one of the problem is that most of older adult people these days are in isolation, and it's necessary to be isolated because this virus is very different. This is a very, very unique situation. But we are so worried about many of the people with mild cognitive insufficiency, mild dementia, Parkinson's disease, depression in elderly people. If that isolation is going to continue for weeks, we're going to see a tremendous clinical presentations of other problems related to older adult people with this isolations going on. This is a very historical moments. I don't have an explanation what should we do. I think definitely what we are working as a geriatric society, try to see what can we do with the better PPE for people that they're able to go to their houses of the older adult people and able to help them with their basic needs, at least make some social interactions for them. I mean, right now, because everybody in the country, they're really worried about their own health issues, and there is definitely lack of PPEs. Till that time, we don't get enough PPEs. We may not able to do that, but I'm hoping, and this is all we are doing these days through the national work, that if we can get more resources, we're able to go to the older adult houses, to senior centers, to skilled nursing home, to assisted living facility, and help them to cope with this fear and danger. The other things that I strongly recommend for the last days, and this is something that also can be helpful for your clients as well. I just share with you something that was just published 2 days ago in Swiss Medical Weekly about discussion about advanced care plan and palliative care for elderly. This is a very, very important time that we need to discuss. I think that was a conversation even I had yesterday with my colleague at New York when they called me for getting help, and because 10 patients in the skilled nursing home suddenly had shortness of breath, transferred to the hospital, and they all passed away in like 2 hours. And then she was sharing with me how we can actually make the national education regarding discussion with family members at this critical moment, that if your loved one has shortness of breath, it really needs to go transfer to the hospital or needs to be ventilated. Do you really want to do it or not? In Switzerland, they're now discussing about we should have advanced care planning right now, as urgent discussion right now, because many of these people, they don't like to die in the hospital. Many of them, they don't want to, like especially elderly living at home. If they are getting the COVID-19 symptoms, what should we do at this point? They're definitely trying to make them more comfortable at home and let them die. Because the other scenario will happen, which I'm sharing with you on the next challenge, will be the challenges that we are facing right now. As you probably hear in Italy and Spain, and also happened in Wuhan, we have age allocation healthcare resources problem, which means that if we have one ventilator and there is a young and old people needs to be connected at the same time to that ventilator, the preference will be for young people. Now, what happened in Lombardy in Italy, you probably hear since last week, many of the elderly people, they had to leave them in the hallway of the hospital till they die there. And in Madrid, in Spain, in the last 72 hours, with some of the conversation I had with one of my colleagues in geriatric medicine in Spain, they technically, the hospital, have this order to let the elderly people die. And because they don't have resources, they have no choice. This is not the situation that we just say, well, they are doing it by purpose or something. No, they don't have any choice. They don't have any critical care specialists. They don't have hospital bed. They don't have oxygen. They don't have anything. That's why they wanted to see elderly people die in this way. I don't want to bring it up as like a panic things, but I'm worried about it, especially what I've seen in New York today. If that happens to our country, and if that situation is going to happen to our country, and then we have the total number of ventilators we have in the area that I live, the area, we may not have like a very, very good scenario. We may have 500 ICU bed in a very good, but counting Kaiser, Stanford, everything, and community hospital. If we have a number of a lot of number of the people, they need critical care, especially based on the populations of California. An estimation of the governor of California, which is a 56% of people getting infected. I know most of them will be mild symptoms, but even 5% of them, it gets to the point that they need to be hospitalized. We're going to have a very overwhelmed acute care, and we're going to have a very overwhelmed situation that we cannot solve it. And if we have infection of the healthcare workers, which I'm so worried about it to be today, then we're going to have the same scenario happen in Spain, that healthcare workers, they got infected, and some of them, they remained escape, and they didn't show up. And many of the elderly people, they left dying in their beds. And 2 days later, the police went and found many of them, they're dead in assisted living facility on their own bed. And that's going to be the biggest challenge. A lot of people says if we don't do anything, if we think about from the population based on the number of the contamination, the people of getting infected, if we really don't know about the ratio of the deaths right now, we take about 0.7%, 0.5%, or 4% of the case fatality rate, the highest number we're going to have a 10 millions of the death, which I hope, and again, we're all praying that we're not going to go that way. But even if it's going to be very optimistic to say if we have only 0.4 to 0.7%, we're still talking about if we don't do anything, means that we just say no lockdown, nothing, but just let the people go back. We're talking about 500,000 at least death in this country based on the number of the infections we have. I wanted to stop here and try to answer your questions. I know that you guys also send me some questions as well, which I'll be happy to answer that questions to you. But and this is my contact number and email if you have any questions or anything we can help you. I'll be happy to help you about it.
Dr. Ayati, this is Donna speaking. Thank you so much for this very, very informative presentation. We greatly appreciate it. From the list of questions, do you prefer that I speak them, or that I can probably talk?
No, please, you can repeat the question. Yeah. That'll be great.
I can talk faster than I can type, and maybe we can get a few of these in here. There's a lot of confusion about who and what is an essential service provider, and because you and I have worked together, you know what our role as professional fiduciaries is, and the role we serve in our clients' lives. We are often their family members, so to speak, because they may not have any family members or the family members they have are not necessarily healthy influences in their lives. Can you help us develop some criteria for consistency and who and what constitutes an essential service provider?
That's true. I think your point is so important, and unfortunately, I mean, one of the things that I'm not a politician, and I don't want to talk about politics right now, but I have to say that we are, and we say we. I'm not saying that I'm not blaming anyone in Capitol Hill or Washington. We actually, in everyone. I think everyone. I remember the time when in the first week of January when this virus started and we are all just observing the situation. We, we have done so bad so far, I have to tell you honestly. And one of the things that we knew that this virus is going to come, we knew it's going to affect our communities. But the problem is that then we only started to become a little bit more concerned when we had some cases in Washington state when they have actually in a skilled nursing home infection. And suddenly all the county public health, they just got panicked. And when it came to our area, like for example in California, suddenly we have a public health ask for court order to stop any visitor in a skilled nursing home and many things without knowing that that should be prepared months ago, that we were been anticipating this situation, which I'm not saying for myself, but this is a conversation we actually made for many people in the last couple of months. We've been emailing, talking to responsible people in this in my area at least, that we should start to preparation for this situation, because I was worried about the older adult people. You're absolutely right. I mean, one of my concern, which actually the topic you brought it up, we actually discussed as a team with other geriatricians, my colleague at other organization, Palo Alto Medical Foundation. I had a conversation with my colleague at Kaiser and also my colleagues at Stanford. The same situation that I say, that a social isolation, many of your clients, they have dementia. And you guys are the main person that actually taking care of them. And now based on the new orders, that everything should be isolated, and they're not allowed to have any visitors to see them.
It's deeply concerning to us as a community because we know these people, and I have the greatest respect for the medical teams, but we could be there to support your efforts and lessen the anxieties of these clients who are in the
The problem is here is honestly all the problem is happening because of lack of the good personal protection equipments.
Yes. Yeah.
The big issue here, if we able to solve this problem, which is we are all doing it. I mean, we are begging everyone right now, all the donors, anything that we can actually get this stuff, even from other countries. We are starting already the movement here to getting some monies and funds to buy some materials from other countries, which is now mainly is actually producing in China, because Chinese people actually producing a lot for the COVID-19 in Wuhan. And we bypass all the regulation and bringing this PPE to let the people able to get to assisted living facility, to get the people's home, to get the skilled nursing home. Currently, I have to tell you that it's a big disaster in our facilities. Most of the facilities, they don't have the appropriate PPEs, and they worry about that if anybody else except the staff, they come there, there's a high chance that they actually spread the infections because they can be asymptomatic and they can infect a person in a skilled nursing or assisted living. I understand their point as well, and they are, and I think till that moment that we have adequate PPEs that we able to provide for people, because my concern as a geriatric patient, which I taking care of many dementia patients, is the dementia patient, and they're really nobody knows what's going on now in memory care units, except the doctors go there and see the patients. I mean, they're already been locked, but now there's double locked, and that's that. I hear you. I mean, that's a big concern. Definitely, you guys are the only person these people have in the life right now, and you are the one that actually helped them with a lot of the decisions making as well.
Right.
I think this is the situation that day by day is changing. We are hoping, and we discuss about because I have a lot of geriatric care managers. They approach me and they ask me the same question: What should we do in this situation? And I talk to many facilities personally by myself, and I hear they're also stand unless they said if the I mean the care manager or fiduciaries they have their own PPE and they can bring it and they can enter to the building. I mean, I have at least 2 or 3 facilities. They told me the same thing, but
Okay.
it's very, very concerning about this.
Yes. Well, as you know, as licensed professional fiduciaries, we often serve as conservators for the people and our clients who live in RCFE or in SNF facilities. And the probate code requires us to visit our clients at least once every 30 days. Now, we're all working with the courts to, this is yeah, unforeseen circumstance, but the social distancing that we're all trying so hard to respect means that we are excluded from these communities and we're unable to fulfill our legal duty to our clients. So I guess we'll all be buying PPE. and
Yeah, I think that's, to be honest with you, the most important thing is that we able to provide more PPEs for
yeah,
people. I mean, if we able to do it, which this is exactly what we all working on it, but as you probably hear in New York, in a skilled nursing home, they actually give one N95 to each staff. They
yeah,
use it for once a week.
yeah,
Means that they actually take the N95 back home and wash it. And you probably saw this morning on the news and CNN, now the people using garbage plastic bag as a gown and
yeah,
in New York to use it.
right.
Um, it's a very, very difficult moment. So I think we never had this experience in our history of medicine, at least I said, since Second World War. I don't think that even we had it on the Second World War period, but I think that's a very difficult time right now, and I'm very concerned that again, till the PPEs is not able to be provided, I don't think that the facilities also they have a better solution for that. But I completely hear you and I completely understand, and this is very important. And as I said in my slides, this is just the beginning. This virus situation, it will continue. And
Yes.
I don't think that the situation is going to finish in the next 1 month or 2 weeks. 2 weeks is just a joke. This is just the beginning, as we saw in the New York for the last 48 hours. This is the beginning. I hope we're not getting there in California. The only way that we able to contain this virus is more testing, 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 and isolate the infected people from non-infected people. That's the only way. This experience shows in South Korea. The experience shows in Wuhan. After 2.5 months, they finally able to go back to some people to the work. Not everyone. Still, a school is shut down in there. But as you probably hear in the last 24 hours, public transportation, limited time of hours started in Wuhan. We are just at the beginning.
Yeah. So I think that's probably the question on the tip of everyone's tongues. I have endured now 1 week of social isolation pursuant to the county health department orders. I'm looking forward, I guess, to another 2 weeks of this. At the end of that period of social isolation and social distancing, does it start to become safe to interact with people more closely than we do during this 2 or 3 week period? Or should we just kind of anticipate that this is going to extend for a month or possibly 2 months? And
It's more.
I know you don't have a
It's
crystal
more.
ball.
It's more than this. I'm not saying. I'm just relying on many of experts in infectious disease. Let me tell you something. As I said during my presentation, this virus has been mutated 2.5 months ago from what we have in Wuhan. The virus, as far as like a structure,
Mhm.
is not the one it was in Wuhan right now. The one is in Italy and Spain, and here is just technically just contaminating many people and killing many people. it has been changed. Now, this virus is keep changing right now because find a different host with a different genetic right now, and it's trying. And the viruses are so smart; they quickly change their structure. And even if we are build some immunity to the viruses that was in Wuhan at the beginning, because the structure of this virus is changing, this situation is not something that is going to be resolvable in like 2 weeks or 2 months. Um, Even the problem is that we are many people anticipating that we're going to have another peak in the next months, especially toward the end of the summer and the beginning of the fall. But it's not going to be as severe as like now because some people are actually able to kind of build immunity. This is exactly what happened in influenza in history and even in the past in SARS or MERS as well. And then that's why still people with influenza and even with development of influenza vaccine, we still have mortality with this disease. I mean, we for many years, we're still not able to make influenza as a case that not killing any person in this planet. No, still, as you remember, 2 years ago, influenza actually killed many people in this area. Many kids in the United States actually died of influenza because the virus is changing the structure. But this COVID-19 is a very interesting SARS-CoV-2. It's a very interesting virus, and I think it's very smart virus, and is because of change of structure, it's not going to be significantly change in the next 1 month or 2 months. This is why everybody's worried if we are removing the social isolation, what's going to happen in the number of the people getting infected.
It's a nimble virus. It seems to me that it's very nimble and it has the ability to mutate again. So we change the rules of the game and it will change how it reacts. What is the best place to get tested?
The best right now, the number of the testing centers are increased. It's much better than last week, I will say. Which area we're talking about? If you are in the Silicon Valley area, right now, many labs of the private labs, commercial labs like a Quest and LabCorp, they also do the testing, but turnover is like 5 days. In my area that I practice, Stanford has Express Care Clinic that actually they do testing as well. Kaiser has a drive-through places for the testing as well. Palo Alto Medical Foundation made a lot of drive-through places as well. For people in a skilled nursing home and assisted living facility, if they call the public health department in the Santa Clara, San Mateo County, they are able to send the people to these places and do the test. Like technically they do swabbing and then they go. We're hoping that the Roche package will be available next week, which is going to be very quick test for 45 minutes. And that's really going to make a change because the only way we're able to fight with this problem if we test entire people in this country. The same thing happened in South Korea. If we're able to test everyone and able to isolate the people are positive from non-positive, then this way we can contain this virus. The same thing happened in SARS, the same thing happened in MERS, the same thing happened in Ebola.
So ideally, we would test everyone. We don't have test kits available for that many tests. So what symptoms would truly warrant we or our clients being tested for COVID-19 at this point?
For our clients, which is more my clients as well, which is a geriatric population, is very difficult because, as I said in my slides, many of them, they don't present with the fever, and the cough is one of the symptoms, and headache, cough, not feeling well overall is going to be one of the initial presentation. And then later they may, if they developed this more moderate to severe disease, they can have a shortness of breath and breathing problem, which at this situation, they need to go to the hospital. But it's a very mild influenza symptoms. The difference between this COVID-19 with influenza, people in influenza in 24 hours, they actually get very bad sick, like they get more high fever, chills. This virus is not. You technically feeling just the mild symptoms for days without any other presentations, and but you're COVID-19 positive. And then some people, as I said in a slide, some people, they only have mild symptoms, they get better gradually in 2 weeks, depends on their immune system. Some people, they go very fast toward a very bad pneumonia and respiratory distress syndrome.
Very good. Okay, doctor, I'm getting flagged that I need to we wrap this up. I really, really appreciate you highlighting the importance of the need to do advanced care planning today.
Mm-hmm.
That is something that we as professional fiduciaries really advocate for our clients. And we so appreciate when the medical community partners with us on that. Just a quick note to everyone who's still on the webinar here. There's a whole nother area, there are many areas, but there's a whole nother area that begs a bit of exploration, and Amy and I are already working on a webinar to present the mental health response to this disease. We've had several situations that we've dealt with relating to mental health, and this disease presents uncertainty in our lives, and uncertainty really rocks the world of the people with mental health issues. So we're working on a webinar on that subject to be announced very soon. Dr. Ayati, thank you so much for all of this information. It's really vital to the work we do. We appreciate partnering with you and our other medical partners to provide the care our clients so dearly need. So thank you.
You're welcome. It was a pleasure.
Okay,
Thank
we'll
you.
sign off now. Thank you everyone for attending.